created man and give brain and give the best shape. Do you agree that we are beautiful? Beautiful than anyone? Do you agree? Yes, we are. Be proud. Say, we are beautiful. Every one of us are unique and we are very, very beautiful. Whether it's a man, handsome, female, all of you are beautiful. All of you. Say it in my word. You are all so beautiful. God made it. And ask, okay, then everybody asks, these people, they are going to make it crazy, A lot of problems happening across the world, because of human. Then the angel asked, why are you making these men who are going to make a lot of problems? Because God told I gave them the brain and thinking different, where others were just praising God only. We were given a way. He started teaching the first man whom we call Adam, different names and different beliefs. He gave all knowledge to him. Knowledge over knowledge. Then finally what happened? He asked all angels, come, this is man. Bend in front of him as a respect. Every angel's bend obeyed God, except one person, that is, you call Satan, right? Or Muslims call it Iblis, whatever you call it. Then you know that human given brain, knowledge, what happened is, our forefathers, we respect all, with all respect, they gave, don't do this, do this. Like if you talk internet, don't do internet these things, do internet these things. Like that, last days also said, do all those things except go to this tree and then take that, what do you call, apple. But finally, they just deviated, gone into the tree, took the apple, God got upset, made them go down from the heaven to this world, erased every memory, all knowledge given as a punishment. Then generations after coming, God is giving us the knowledge. We are going back. We are inventing. We call innovation. We call it R&D. We call whatever name. We are reading. We are regenerating. We are going back to see the God's given knowledge is coming back to us. So do you now believe that we have a better knowledge than the artificial intelligence? Do you all agree with me? Yes, then get ready for a future. The artificial intelligence is going to be ahead of you. They will be ahead of you. If you are not showing more enthusiasm in the auditorium even, if you are not energetic, if you are not taking the challenge of tomorrow, learn more. Understand more what's the world is going, what's happening all around the world. Even in our medical side, the doctors are going to talk about you. That's why we are here. In the part of capacity building, Astro volunteers strongly believe about capacity building, which is our core focus, training and development, coaching program. This is one of the incidents we are going to give you knowledge. And the mobile clinic, because we have a healthcare program, we reach out to 23 countries through that program, through 71 mobile clinic recently. And this is the 67th one, if I'm not mistaken. Dr. Kagaba all were in Dubai to Flago. Finally, it reached here with the support of Ministry of Health, the HDI, our great partner, with the support of Astradium Foundation, the Astro volunteer leading through Astro Hospitals and Clinic. It is now your property. We are dedicating to you. You are all busy, we are all busy. We are all times busy, but ensure that you are taking a pledge today to work with your ministry, with your university, with your team here, and do some sort of a volunteering. The knowledge what God give you, the fortune you get it, give something back, if not material, your time. And I'm sure that we can make a wonderful world. And I'm so confident moving out various countries, and I'm touching and talking to you. Rwanda would be one of the best in the region, in the continent, going to drive future of healthcare. And you can be proud of Uganda. It's such a beautiful country. We are very happy, and we will be your partner in the journey together. Jai Rwanda, Jai India, Jai Gulf. Thank you. Bye.
Another round of applause for Jalil. So, before we move on, I would like people at the technical team to give some microphones with the help of the protocol. And we take like three of you, I mean medical students, and you'll be telling us what is all you know about mobile clinics. Like, is it your first time you have heard of it? What do you think is going to bring? Like, anyone, any volunteer? And I need gender balance. A girl, a boy. We do it as quick as possible so that we buy time. Anyone from this side? They've come to tell us that we can also use AI. If you are not sure, you can just go to Google and you get what to answer. If you don't know, or if you don't know, you can just say and we'll talk about it. Any volunteer, what you just think about? Anyone? Anyone? Oh, okay, I'll just speak. The girl with natural hair. What do you think about a mobile clinic?
Thank you. My name is Jacinta Gloria Wimana. About what I gained for this presentation, about that mobile clinics, I keep asking myself about, may this project work with the RSSB or public insurance? May every people in Rwanda access that service? Thank you.
Thank you very much. So the question came with another question, but it's okay, that's what we want. Anyone else? We are recording it, we are keeping it for being answered. There is someone here in front. Okay.
Thank you. What I know about the mobile clinic is that it's a health facility which goes to the communities. It's like a van or a bus, which is equipped with medical instruments or medical equipment. And it goes with the healthcare professionals, where they go to the communities and provide services to the communities, to the people in the community. Thank you.
A big, big, big round of applause. Your name again? Excuse me, your name again?
My name is Vincent Irambona.
Vincent Irambona. Where, like, what level and what department are you from?
I'm in dental therapy year 3.
Thank you very much. Yeah. So we are accepting one more. I've seen someone raising a hand here in the middle.
Thank you. My name is Ngabire Ntime Christella. I'm a student in mental health nursing level 3. What I know about the mobile clinics is, like my colleague said, it's a kind of clinic that delivers service to people where they are in the community. Like for us in mental health nursing field, we know that some people, they have stigma about the mental illnesses or mental disorders. Some people, they are taking medications, but due to that stigma, they fail to comply with medication adherence. Or those people with NCDs, sometimes fail to comply with the medication adherence due to different challenges like transportation costs and other challenges. So the mobile clinic is a kind of clinic that's going to solve the problem of those people who have difficulty with getting medical services in hospitals. So it is going to deliver health services to people where they are in the communities. Thank you.
Thank you very much. All insightful suggestions, insightful questions, and I think you have been answered from your colleagues. So mobile clinics are bringing a good impact in the prevention, mostly because what we hear about mobile, they are not going to be at a static. Like if you go to maybe Sehashika or you go to maybe any of the health posts, so it's going to be moving around for helping people get early detection for diseases. And from that, we'll be talking about non-communicable diseases that we know, like hypertension, diabetes, and also there will be screening some more other diseases. So this will help in early prevention and early detection. So thank you very much for your insightful additions. So as we continue on our agenda, we are going to have a recognition time for our partners. So if you allow me, I will call you in front at the stage for recognition, and as we have a group photo. So allow me to welcome Dr. David Turatsinze. He's the president of Rwanda Physician Association. Not here yet. It's okay. Thank you very much. So let me call upon Dr. John Baptiste Muranga, the president of Rwanda Medical Association. So he has not yet arrived. I would like to call upon the representatives of the Indian High Commission. You are welcome on the stage. Not yet. I would like to welcome the representative of the University of Rwanda. Thank you very much. I would like to call upon the HDI officials. Yeah, we are going to have a recognition here in front and also a group photo. So we are honored to welcome also HDI officials, Dr. Kagaba and Dr. Dan. Allow me also to welcome the ASTA volunteers, Rwanda representatives, Mr. Richard Kabera. Thank you very much. Allow me to welcome the ASTA volunteers from UAE, the United Arab Emirates delegates. You are welcome on stage. Thank you. I would also like to call all the speakers that we will have today to also join us on stage. All the speakers you are welcome on stage. So this is for the recognition. Thank you very much for making this happen. We are going to take a group photo and we'll proceed with the agenda. Thank you. Okay, so we'd like to call upon all the HDI team. Please come in front as we proceed with the inauguration. Please, HDI team. HDI team. So Shanavas, please, we need you in front. Thank you very much. We would also like to welcome the student representative. The student representative, you are also welcome on stage. We need Shanavas in front, please, if you can hear us. Thank you very much. So we will proceed with our next session. I would like to request you to join us outside for the handover ceremony. So for us, we'll be staying for a short time here in the hall as we proceed with the handover ceremony outside. Thank you.
So, dear students, just bear with us. We had a plan to have the flag off ceremony there telecasted here. And you were all watching from your seat, that was the arrangement. And you know that superpower, which I said, is above all of us. He is not yet fixed the technical issues through our technicians. So we are switching the program without delay to ensure that you are able to move after attending our sessions of doctors. The doctors, I spoke everyone, they are confident to present even without this one. So they are so prepared to engage with you. So don't worry about it. In 5-10 minutes time, we are going to come back. Until then, just relax. And we will be sharing you. We have make a mechanism. The flag off ceremony event will be shared to all of you through the university administration. So you will be part of it. Until then, just relax 5 minutes, 10 minutes. We are going to be come back. Okay? Thank you. Sorry, that superpower is beyond all of us. Okay.
such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Loving when you stir it up, that body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why. a shana you go bright too. All again for the night. Happiness. If I broke now my business, I'm a shana you go bright too. All again for the night. Happiness. If I broke now my business, I'm a shana you go bright too. All again for the night. Happiness. If I broke now my business, I'm a shana you go bright too. All again for the night.
So this is the mobile clinic that has been launched. The activity we are from. So you can have a look on the screen, but you will have some time to be explained on how it works and the impact it's going to bring for us. So thank you very much. We are going through our agenda. So on our next session, as the second part of our conference or our event, we are going to have a medical conference. We are going to hear from different doctors, from their perspectives on different topics. And without taking much of your time, I would like to call upon our first presenter. So allow me to welcome Dr. Prakash Nail for the presentation. He's going to be talking about the neurosurgery in contemporary times. Dr. Prakash Nail, you are welcome. The technical team, please help us with projecting the presentation. Thank you.
many people are fascinated by it, but then it's such a tough field that most of them leave it midway and go. So it's a really demanding thing. The rewards are very high, and you need to change your perception like what it was, around 20, 25 years back, when people would think that you had a brain surgery or a spine surgery, and then, you end up paralyzed or you are bedridden and all those things. Times have changed. Neurosurgery is highly rewarding. You can have the best possible outcomes in a patient. They can thank you for the rest of your life. But yeah, it comes at a price, So as a surgeon, you need to focus on doing the best for your patient. So today's topic is like what neurosurgery is in contemporary times. So how it has changed according to our times. So I am Dr. Prakash Nair, consultant neurosurgeon. I work in Dubai, Aster Hospital. And next slide, please. So this is the beautiful place where I work. It's a multi-specialty hospital wherein we deal with all sorts of complex surgeries, brain and spine, and it is a tertiary referral center. Next slide. So evolution of neurosurgery. Neurosurgery is a very, very old specialty. So we have found skulls dating back to around 3,000, 4,000 years, especially in Africa and South America. So this is a famous skull. The previous slide, please. This is a famous skull of a lady, and it shows a hole in this skull, which is actually called as trephination. Now, why this hole was done, whether it is part of any ritual or whether it was some punishment given or whether it was actually a medical treatment. But it seems that they opened the skull for some medical treatment because there are signs of healing around the edges of the skull, which implies that the patient was alive after the procedure for some time. So that means probably it was done to save the life of a patient. So neurosurgery nobody wanted to do neurosurgery until this man came, Dr. Harvey Cushing, the father of neurosurgery, an American doctor. People would not take up neurosurgery because it was the results were very poor till Harvey Cushing was forced into neurosurgery by his seniors. But he slowly sat on it, thought about how to do neurosurgery because the principles of neurosurgery are entirely different to that of general surgery. General surgery, we are taught that you should always stop bleeding by applying pressure. However, in neurosurgery, you can't do that. You can't apply pressure on the brain. So, Harvey Cushing devised techniques, and I'm really proud to tell that most of the modern techniques in surgical practice have come from neurosurgery, like BP monitoring during anesthesia, electrocauterization, bone wax, which is used by the orthopedic surgeons. All of these inventions are come from neurosurgery, and all of them are by Harvey Cushing. He brought about a significant reduction in the mortality, maybe from around 100%, he brought it around to 40%. Many other neurosurgeons contributed in some small way or the other big ways, but the next major advancement was by this gentleman, Dr. Ghazi Yasargil, who was voted as the neurosurgeon of the century. And he was a Turkish neurosurgeon working in Switzerland, and he introduced microscope to neurosurgery and brought about a section of neurosurgery called as microneurosurgery. This involved studying the anatomy of the brain in great detail, which gave us insights into the natural history of diseases, and we could treat them even in better possible way. Okay, so what is the aim of this talk is to orient yourself. It is just basically a talk for the general population, the general physicians, students, and not for neurosurgeons. This is not a complex high-end talk. It is just to orient you about the diseases that we have in your community, and slowly these diseases are rising in our community. So the earlier identification of these diseases, proper referral to tertiary centers and bringing about the change in the life of the patient, that is the aim of this talk. Faulty perceptions, fear of outcomes has to be erased. Now, decision makings are very important because you cannot guarantee their outcomes, and therefore the decision making is a combined decision between the doctor as well as the patient and the relatives. There is a high probability that you might end up paralyzed or you might lose your life. So a proper discussion before initiating treatment is the key to approach any neurosurgical diseases. Now, present day neurosurgery is becoming more and more complex because of more technological advancements. The common things that we see are that people are driving more vehicles, so the more chances of head injuries, accidents, strokes are increasing because of faulty lifestyles, which may be ischemic or hemorrhagic stroke, or it can be a deadly thing called a subarachnoid hemorrhage, which is due to aneurysm rupture. Outcomes have improved recently, but still there is a significant morbidity and mortality. Coming to the diagnosis, all these things are what mentioned are the diagnosis. X-rays are slowly fading away because we have better modality sensors. MRI, it started as a 0.5 Tesla MRI. Now we have 3.5, 5 Tesla MRIs also. Other accessory investigations are needed as per the required diseases. So imaging has improved, microscopes, endoscopes, resolutions have improved, stereotaxy as navigation has come. That actually helps to just like you have a Google map, so you can map the entire brain and you can decide where to operate, how much to operate, etc. Robotics and artificial intelligence is there. This is a model, next slide please. This is a modern OT. You can see the amount of wires, instruments, etc. This is done in one of our patients. Like we fix the head in a skull clamp, and then it is connected to monitors. So the preparation and positioning of the surgery itself takes around 1 to 2 hours before we start the surgery. Next slide. This is another view of the patient. Next slide. So this is the latest high-end microscope which we use. The previous slide, please. So this is the high-end microscope that we use, and it's a huge instrument but very easy to navigate. It has got many other additional filters, and it can be integrated very well into your computer, softwares, the scans, etc. And what we see in the bottom slide is what I was talking about, navigation, wherein you can map the brain in all directions. You can measure what is the tumor. You can pass the instruments. While passing the instruments, you can see it live on the screen that where you are going, are you striking the right object or not. So these are all the latest advancements that we have. This is a new thing. Metallurgy has changed. Like we used to put screws and all, which were stainless steel screws. And stainless steel screws are notorious actually. They are magnetic. You can't do an MRI later on. So we found out, people found out titanium. Titanium screws are better, and they don't react with the body. They are stronger. We used to do bone flaps, reconstruct the bones, skull bones and all. Initially it was acrylic, which we used to mold it with the hand. Nowadays you have 3D printers which give you the accurate contour of the skull. Two other things that have come up very in big ways. PEEK. PEEK stands for polyethyl ethane ketone, and HAP, that is hydroxyapatite. These are analogous to almost like bone, but they come a bit expensive. In Dubai, we are using most of our things are all PEEK and titanium. Next slide. So let's start early days of becoming a neurosurgeon. Like it's usually a subspecialty of general surgery. You need to be dependent on general surgeons, the Department of General Surgery for getting cases, managing them and all. There will be a lack of equipments. So you will have basic equipments, do basic surgeries. You have to understand the limitations of your community, the administration, the financial aspects in getting huge investments, because neurosurgery requires a lot of investment, and the department just starts slowly grinding all along the way. Next slide. Then you have an increase in patient loads. Then you need assistants. You have to train assistants, start a training program. Then there is always a paradox of a junior doctor. Now what this is that like every patient wants to be treated by the best doctor in the community. However, if that is the case, then how will the junior doctors learn? So there has to be a collaboration between the junior doctor as well as the senior doctor, and that should be a supervised training. Again, here the health authority, proper certification, all those come into picture. And finally, you form a small team, that is the Department of Neurosurgery. Next slide. Then you need other specialties like radiology, pathology, neurology, oncology for discussions, for managing, for further treatment care. Interventional neuroradiology is hard to get, but you need it as your department progresses further. Physiotherapy is one of the key aspects of all neurosurgical problems, and you need a very, very good physiotherapy department to manage your cases after they have, you're operated or something. You have to attend new conference, learn new friends, learn new ideas so that you can implement it in your system. And of course, after that, slowly, you have to publish your cases, do research and other things. Next slide. Now, as you gain confidence, you feel like doing more complex cases. However, the problem with complex cases is that they only form a small majority of the patients. The main thing is the common cases. So you need to become an expert in doing the common cases before you jump into more rare cases, because rare cases need different modalities of treatment which are expensive and the complications may be high. So, and then slowly to offset that, to increase the number of rare cases, you can form a tertiary referral unit so that the entire area around you, they refer cases to you. Next slide. This is a big thing. As you keep on increasing the complexity of cases, your complications also rise. So there is a difference between failure and managing failures and negligence. Failures, everybody has faced failures. There is like, even I have faced a lot of failures, but negligence is something which you are answerable to yourself. If you are suboptimally committed to the patient, then I think probably you are doing a disservice to the patient as well as the community. Medical legal issues can come. Neurosurgery, especially the spine surgery, is very much prone to neurosurgical litigations, but you have to stand strong to it. And here, a community of doctors definitely helps you weather the storm. Now, what are the takeaway points are like times have changed. You can be more happy about neurosurgery, that results are more good. Decisions are difficult to make, but yeah, you need a lot of communication, that is important. And trauma and stroke are becoming the bigger killers now. So there is a scope for, getting more neurosurgeons into the community. And the last thing, as I said, is neurological diseases can be devastating. It affects the whole community as a whole. So these are some of the cases. This gentleman, actually, you can see that between the two screws, there is a fracture of the vertebra. He was an electrician, just fell off from the roof, came with weakness of all 4 limbs. And we did this surgery, put a plate and screws. These are titanium plate and screws. And it's 2 months down the lane, he's walking. His power, if you say, is able to do all his activities by himself, just suboptimally. He's not the same as before, probably has gained 90% of his power. So this is another case. You can see clearly that the neck is broken and the alignment is completely, spinal cord is kind of transected. He also was completely paraplegic. Next line. So this is what we did from him. The serrated tube is the anterior part. The posterior part is, you find the 2 long rods. We fixed him posteriorly, then turned him around anteriorly. So this is the lateral view of the X-ray, and the other side is you have the anterior posterior view. So he actually was completely bedridden, but I think after 3 months of surgery, physiotherapy and all, he could at least sit in a wheelchair. I'm not yet sure. He went back to his home country. He was from Nepal. This is a more complicated thing. The white thing that you see is a tumor which is entered into the spinal canal as well as in the lungs. So we had to do 2 surgeries at a time. That is, remove the tumor from the spinal canal and then did a thoracotomy to remove the tumor from the lung. He's doing very well. Next slide. So this patient was retired policeman. So he came to me with this X-ray where you can see that the blocks are the vertebra, the black are the disc, and the area behind the disc is the spinal nerves. So you can see all the nerves are just compressed, pinched at many levels. So he required a real complex surgery. And in these surgeries, what we do is like we remove the discs and place something like that. That is a PEEK thing, implant, wherein you find a screw at the end. So when you put a screw, it expands. Next slide. So this is the surgery that we did for him. Put him a screws, put 3 PEEK implants, widened off, and this gentleman who could not walk started walking again. It is around 7 months after the surgery. So he's from Africa only. He had come last month to pay me a visit. And this is a final slide of brain surgery wherein this gentleman had an accident, bike accident. So they did a surgery for him, but unfortunately his skull has become damaged. So now what we plan to do, the figure on the right is the model that we have made, a PEEK model. This is done by 3D printing. So the order is ready. We are waiting for the model to come. Probably by the next week, we'll fix the skull to his skull bone flap. So these are some interesting things in neurosurgery. Next slide. So thank you for your patient listening. And I'm very proud, like just before coming, I got this thing, Newsweek 2026 rankings, and my hospital is 4th best in the UAE world rankings. So that's all. Thanks a lot.
So thank you very much. Another round of applause to thank the doctor. So actually, on my side, I thought neurosurgery was a very fearful topic to talk about. But he reminded us that with experience, with time, you get to, you start with a more, okay, neurosurgery doesn't have an easy surgery. You start with maybe what we can call an easy one, and then you go to more complex ones. So it just takes time for us to get more experience. So thank you very much, doctor. So is there anyone with a question? We'll have one question, and if there is none, we'll proceed with our agenda. Any question? So thank you very much, doctor. Yes. Thank you very much. So we are going to continue with the agenda. We are going to see how Aster impacted the community through the people, as I mentioned before. They have helped around 7.7 million of people in the community. So we are going to see all about the activities, the journey that they have been going through. So we are going to have it through the video that they are going to play. So as we are waiting for the video, I would like to call upon Dr. Kagawa to hand over the recognition for Dr. Prakash. Thank you very much, Dr. Prakash. Thank you very much. So we continue, we proceed with the video. Please, technical team, can play the video. Thank you very much. I've liked one of the, there is two sentences that is written on the, has been written in the subtitles, but the video talks itself. But I like the words that they say that they took one step and 1,000 more followed. And I think we can also be those who follow the step. Okay? Okay? Do you accept or not? Can we join the steps that they have took at the first time they decided to do that? And they have also said that all their achievements they are possible. And I think we can also, after this, we can also have the testimony from this video. So thank you very much for sharing the achievements, and I think we can learn from this as we also improve. So thank you very much. Let's proceed with our agenda, and we are going to have also another interesting talk from Dr. Edwin Francis, the Director and Senior Consultant at the Asta Med City, Kochi, and he's a pediatric cardiologist. So we are going to hear from him. He's going to give us a session on congenital heart disease in children, and he's going to focus more on early detection and screening models to reduce childhood cardiac mortality. Dr. Francis, you are welcome. And excuse me for speakers, you are going to have 10 minutes presentation and 5 minutes for questions as we buy time. Thank you.
Good evening, everyone. It's been great to this great country. Thanks to the Rwandan authorities, ASTA management, and ASTA volunteers, especially Mr. Janil in making this happen. It's a great event. So probably the next, in few, 10, 12 minutes, I'll try to go through what's about screening and early detection of congenital heart disease. So as you all know, the congenital heart disease is around 1 in 100, globally, contributes significantly to the infant mortality and less than 5 years mortality. Over the world, anywhere in the place, the incidence of, say, 0.8 or 1 in 100 is standard over the world. So early detection dramatically, why we are pushing on is early detection. It dramatically improves outcomes, and screening and referral system reduces the late presentations. So why early detection? The many critical heart diseases which the newborns, the babies are born with, are not immediately apparent to the clinician, to me and you. And it comes later, by the time there may be damage has all been done. That is why we tend to go in early. So what is, in this area, we're going to focus upon what is critical congenital heart disease. I think my colleague will speak on the common congenital heart disease. I'll focus on, as you all know, it could be an atrial septal defect, a ventricular septal defect, a tetralogy of Fallot. These are ones you would have learned in your first few years of medical school. But when you say a critical congenital heart disease, are those conditions which require intervention within the first year of life. If you don't identify them, you don't treat them, you get into trouble. That's why it's called a critical congenital heart disease. And examples are like transposition of great arteries, total anomalous pulmonary venous drainage, hyperplastic left heart, and tetralogy, which is more often you may see, or a coarctation of aorta. I'll just give you a cartoons, next slide, on which it gives you examples. This is the first example, is the one on the left side, is a healthy heart, the normal heart, as you all know. The unoxygenated, deoxygenated blood comes from the right side, goes to the lungs, get oxygenated, and comes to the left side and supplies the body through the aorta that you all know. So tetralogy is the first one in the left side, is the one which is most common congenital heart disease, cyanotic congenital heart disease, which gets you into trouble. If you don't treat them, almost 40% die within first 2 years of life. So it is associated with a large VSD, a ventricular septal defect, and obstruction to the right ventricle. So this causes deoxygenated blood moving from the right to the left, so causing desaturation and problems. This is one of the most common one. And the second slide gives you a transpose of great arteries in which the right ventricle, which is supposedly supplies the pulmonary artery, which should go into the lungs, instead of that, the aorta comes from the right ventricle. So the patient doesn't live if you don't immediately treat within few days. The third diagram shows a total anomalous pulmonary venous drainage in which the pulmonary veins, which should come to the left side of the body, to the heart, comes to the right side. Again, gets you into trouble. The last one shows a severe coarctation in which the significant obstruction to the main blood vessels, which comes out of the heart, again gets you into trouble. So these are the major heart diseases. So what does screening do? It is just early detection and then early referral, you identify a timely intervention and improves better outcomes. So just go through some of your health standards in your own country, Rwanda. They say just get through the internet, so just correct me if I'm wrong. They say it's around 40, and the infant less than 5-year mortality is 40 per 1,000 births. And the infant mortality is around 30 per live birth. So what are the main causes? When it was even worse earlier, every developing country, including India, goes through that. So it is infections, malnutrition, prematurity, and asphyxia. These are most common causes which causes this infant mortality rate. And the congenital heart disease, which is a smaller proportion in the early era, now becomes more prominent because the more correctable conditions like infections are taken care of as the country proceeds. Like even I think Rwanda develops at the rate of 8%, the economic progress is happening at the 8%, something similar to India. Next one. So what I try to focus on is that just a simple pie diagram, don't bother about the too many colors here. The main thing I want to show you is that the percentage of contribution of congenital heart disease is only 4% when your infant mortality rate is 50 or 60. But when it's coming down to 20, 30, it becomes predominant, like 4% in the right of the screen becomes 39% the contribution to the infant mortality rate. That is why, actually, like developing countries like India and Rwanda, when we need to move on, when the infant mortality rate comes down, the proportion of the contribution from the congenital heart diseases becomes quite significant. This is the study, first one was 2015, and now this is from 2024 from a developing country. So this is a scenario in most of the developing countries. So just give you a snapshot of what happens in India. It's almost same, like again, we have a significant reduction, like in Rwanda, there's a significant reduction in infant mortality rate to our last 3 decades, despite there are significant regional disparities. So it is something like 19 neonatal mortality rate, 25 here is around 30, and the less than 5-year mortality rate is 28, here it's around 40, almost a similar states. But when it comes to Kerala, I come from a small state in India. India is huge, 1.4 billion people. And we and my chairperson and Mr. Janil all come from a small state in the southern tip of India, in which we have health parameters which are comparable with the developed world. So we have in Kerala, we had brought down the infant mortality rate to single digit. It was something like around 12 to 15, 4 to 10 years ago. The main success story, even though in India it is high, in Kerala it is low because of the female literacy, education, and sanitation. But we were in that same around 12, 15 for almost a decade. The further reduction to a single digit, which happened recently, to the number 6 we quoted here, is because of focused early detection and targeted intervention in congenital heart disease. Next slide, please. So what are these targeted interventions? This happens with a government association, what we call it a public-private partnership, what this Astra Volunteers is trying to do. The screening and detection mostly happens in government hospitals, while targeted treatment occurs in more private places. Slowly, as the capacity builds in government hospitals, we improve upon that. One thing we just focus here is comparing our standards with the United States. Here, you see our per capita income is something like $3,000 USD per year, while in the US is 68,000. Our parameters, next slide, I just focused on those arrows coming in. Just press on the next button. Yeah, just want to focus here is that with a per capita income of something like $3,000 compared to United States 68,000, we have a infant mortality rate almost similar to United States or even lower. So money alone is not the matter. The focus and the persistent application and interest makes a difference. Next slide. So I think we should be able to replicate what the Kerala model, the Kerala story in any country, especially in Rwanda. It's already well developed. If rough estimates, with the population, I think you have a population of around 14 million. In Kerala, we have something like 34 million. So birth rate is slightly higher here. We have a slightly lower birth rate. You may have around 2,000 to 2,500 babies born with congenital heart disease. So 1/3 of them, any disease of these will have critical heart disease which require treatment. And timely intervention help them prevent getting into trouble. Next. So screening method, I'll just quickly go through what are the screening methods which are possible. One is fetal echocardiogram, routine clinical examination, pulse oximetry, and next one is the screening echocardiogram. I kept these two, the previous slide. The routine clinical examination pulse oximetry as a screening test because other two are a bit more difficult to perform and more easier and cheaper. Next one. So what is a screening test? I think you would have studied in your first few years in the medical school. A screening test is a test done in the general population to identify a specific disease. So what exactly should be a screening test? It should be simple, cheap, accessible, and high sensitivity and specificity. None of the tests you know that will not be ideal, but we look at what is the best screening test. This next slide. So a fetal echocardiogram, even though it is if you are done by a good technician or a doctor with a good machine, it can pick up almost many things. But again, the problem is you need a good personnel which is highly qualified, and equipment also matters. So again, it becomes difficult. Next slide. So thus comes pulse oximetry. It's quite simple. It is usually done 24 hours after birth, and then done in the right upper limb and the right lower limb. If it is negative, that it is normal, is if the saturation is 95% or more, or the difference in saturation between the upper limb and lower limb is less than 3%. Next one. So if it is borderline, it's between 90 to 95%, and if it is positive, if its value is less than 90%, or repeated values are below 94%. So a quite simple test can be done by anybody. You can train any non-clinical person to do this quite easily in the periphery. So why pulse oximetry? As I said, the newborns with critical heart disease doesn't present immediately with symptoms. Physical examination, as you all know, has its own limitations, and many symptoms develop after discharge. An early diagnosis prevent center. Even in developed countries, like this study from Shanghai recently, which showed a screening improves survival. Next one. Well, again, same thing, it just improves mortality and disability. I think short of time we'll move on. I just thought of I was reading this book last year. So it just says that it was written by this Phil Knight, who had started this company, Nike, in which he says that the beginner's mind has many possibilities, while an expert's mind has few. So it's always better to have a beginner's mind so that you keep all the possibilities in your mind. It's always good. Next one. So what is possible here? A newborn screening at delivery points, community health worker being trained, regional referral and referral network, capacity building and public awareness. And what an Astor can contribute is helping in the lodging in the medical units. Next one. Next slide. We can help in local clinicians and community health workers, regional training and observership for doctors with the Astor hospitals to do high-end job. And knowledge shared is the care multiplied. Integrated referral systems and teleconsultation network can be done. Telemedicine can can be used to support diagnosis, reviewing cases, and follow-up of high-risk infants. And research projects between Astor and Rwandan health authorities and clinicians could be possible. Next one. And expanded research programs, it includes CST awareness for parents, caregivers, and community leaders could be possible with Astor volunteers. And just I'll quote another book I was recently reading, A Good to Great. This gives you like about a flywheel mechanism effect, in which you focus on small things. Don't try to get a big sudden change and then keep doing it. This is called this flywheel, this things effect, in which more things to happen in future. Next. So what is the impact expected is that a stronger newborn and pediatrics training systems, local capacity building, improved infant and child survival. And what in Astor gain in turn is knowledge exchange in clinical learning, long-term partnership with government and NGOs, and enhanced global leadership and brand value for our own. So this final slide is that a hedgehog concept in which You focus on one area specific which you are passionate about and which you are best in it, and then look into the economics, all three, focus on it, and then you can achieve greater things. Next one. So you can achieve the targets of 2030. To conclude, next one. Next one. The early detection treatment improves survival in CHD. This in turn helps to reduce infant mortality rate. We can build a system, every heartbeat responds to every need. And next one. And locally rooted and globally inspired. Thank you.
So thank you very much, Dr. Francis. As we recognize his good impact through his presentation, has told us many things, and I hope everyone retained. So as they recognize his impact, I would like to share with you what I have got from his presentation. From his conclusion, he reminded us that we should focus on early detection and early prevention. And from the quote he shared us, he also reminded us that it is always to have a beginner's mind, because there are more possibilities. So from this, I've caught that if you have that expert mind, you can just look for the signs and symptoms that would be more complex. And we have seen that for newborns, it's hard to detect those complex symptoms and signs. So it's better to have those beginner's mind for us to detect earlier from those simple signs, for example, using those pulse oximeters. So thank you very much, Dr. Francis. So as we proceed, we are going to first have a word from our guest of honor of today. I would like that the technical team can be preparing the video. So we are going to hear...
everyone, Your Excellency, Honorable Minister of Health, Honorable High Commissioner from India, distinguished guests from the healthcare fraternity. It is a profound honor for me to be with all of you here online today. In a nation that has become synonymous with one of the world's most inspiring stories of resilience, transformation, as well as ambition. Rwanda does not just talk about the future, it is truly building it, and that is exactly what brings us to this conversation today. Let me take a moment to introduce all of you to Aster DM Healthcare. My name is Alicia Mupin, and I am the Managing Director for Aster DM Healthcare. Aster was started almost 40 years ago by my father, Dr. Azad Mupin, who came to Dubai with a very simple but powerful belief that quality healthcare should not be a privilege reserved for a few, and it should be accessible to every patient regardless of geography or income. Today, we are one of the largest integrated healthcare providers across Middle East and India, spanning across UAE, Saudi Arabia, Qatar, Bahrain, Jordan, and India. Today, we serve more than 27 million patients annually across our network of hospitals, clinics, and pharmacies, which are more than 1,100 in number. We are a brand built on clinical excellence and equally on compassion. Now, healthcare access is not just a noble aspiration. We truly believe it is a fundamental human right. And yet for a vast population across Africa and South Asia, geography, cost, and infrastructure remain formidable barriers and challenge. At Aster, social responsibility is not a footnote in our annual report. It is embedded in our model. Through the Aster Volunteers movement, we have mobilized thousands of healthcare professionals for community outreach. Through subsidized care models, we ensure that our facilities are not gated communities for the wealthy. In India, over 30% of our patients at certain facilities are served through our government schemes and charitable care. In the Middle East, we have been a trusted healthcare partner to the migrant worker community, often the most vulnerable as well as the underserved. We believe that how you treat the least visible patient in the room is the truest measure of your values as a healthcare operator and provider. Now moving on to Africa and Africa's superpower. This brings me to what I believe is the most important and most exciting part of our conversation today. When we speak about the future of healthcare in Africa, we always must resist the temptation to simply transplant Western models onto African soil. The infrastructure is different, the disease burden is different, the economic realities are truly different, and yet the ambition and the intelligence is every bit as formidable. Africa's answer, just like how India's answer has been unfolding, is through frugal innovation, the art of being able to do more with less without ever compromising on quality. Look at what is already happening. Rwanda's drone delivery network by Zipline is delivering blood and vaccines to remote health centers faster than any road-based systems. Community health workers equipped with smartphones are diagnosing tuberculosis and malaria in villages that have no hospital within 50-kilometer radius. Solar-powered diagnostic equipment is reaching off-grid clinics. AI triage tools are being deployed on basic handsets with limited connectivity. Africa is not waiting for the world to build solutions for it. Africa is building its own, and Rwanda is leading at that. The key ingredients are already here. You have a young, tech-native population, mobile-first infrastructure, a strong community health worker backbone, and a growing culture of entrepreneurship and problem solving. What Africa needs now is investment, not charity, but strategic partnership. It needs policy frameworks that incentivize local innovation rather than penalize it. And it needs collaborations between governments, private sector, and institutions that are being represented in this room. The presence of the Health Commissioner from India in this room is also deeply meaningful. India and Africa shape more than diplomatic ties. We share a common journey towards health equity. India's generic pharmaceutical industry has saved millions of lives across Africa. India's low-cost diagnostic innovations, telemedicine models, and Ayushman Bharat digital health framework hold real lessons for this continent. It is a partnership that is not on dependency, but on solidarity and shared aspirations. And Aster is proud to stand at this intersection. Excellencies, ladies and gentlemen, the future of healthcare will not be written in the boardrooms of London or New York. It will be written here in Africa, in Rwanda, in Lagos, in Chennai, and in every community where a determined health worker is finding a way to save our life with the tools that they have. Our responsibility as leaders, as institutions, and as innovators is to ensure that the next chapter of global health is one of equity, ingenuity, and shared humanity. At Aster, we are committed to being part of that story, and we are honored to walk with the path with you, all of you. Thank you so much.
Thank you so much. That was our guest of honor for today. She was not around here, but she made it to give us a word that I think everyone should take a message from. She reminded us that we got everything that we have, so we need to put in the collaboration to achieve that healthcare development that we want as a team, as a collaboration. So thank you very much from our guest of honor for today. So as we proceed to our agenda, I would like to call upon our next presenter. So we are going to have a presentation from Dr. Ntaganda Evariste, the director of the Cardiovascular Diseases Program in in RBC, and he's going to be presenting on Rwanda's healthcare vision and regional hub strategy. So you are welcome, Dr. Evarist, on the stage. So let's give him a round of applause as he comes on the stage. Thank you. For a reminder, we have 10 minutes for presentation and 5 minutes for questions.
Hello, can I say good evening to you? As it is written, I'm Dr. Evarist. I'm reading cardiovascular disease program at Rwanda Biomedical Center. Next. I have an outline of the presentations. Next, please. So Rwanda has a vision 2050 to become upper middle income country by 2035, and then high income by 2050. On health, we have to have high quality and standards of life for Rwandans. We have also national strategy for transformation NST2 that will address on the health side to address human capital, quality health services, disease prevention, and technological transformation. And also, our strategy is also concern universal health coverage. Here in terms of geographic accessibility and financial accessibility, this is how we have been doing, and as you know, we use decentralization of services, and also most of the services should be paid by community health insurance. And that's when we're talking about accessibility or universal health coverage. We want to talk about geographic accessibility and financial accessibility, and that's where we come in. So we also have to think about private sector led growth model. This is another approach. So Rwanda, strong government leadership and reform-driven ecosystem. Rwanda is transforming into a regional health care and science hub. We're focusing on quality, accessibility, as I said, innovation, and also sustainability. When we talk about, if I can talk on sustainability, I remember when we were training, we depended on support from all over the countries, around countries, Uganda, Kenya, but I'm sure when you come back currently, our professors are now Rwanda-made, if I can say. So this is another sign of sustainability. Strategic opportunity for private sector and international partners. This is what we're doing here. Thanks to you and the HDI for bringing up this one board. Clear roadmap, infrastructure, workforce, digital health, and medical tourism, then biotechnology. Next. So the pillars are as follows. We have infrastructure. We need to talk about human capital development, digital health and ecosystem and data systems, then pharmaceutical and biotechnology development, then medical tourism and international patients. So we need to, these are the pillars that we are trying to build on. Next. So expected outcome, reduction in foreign medical expenditure. We have been, all along, trying to refer patients outside. So this is one of the things we need to resolve in one of the things. So we need also to create job creation. As I said, one of the approaches is to use private, so we need people to invest in medical field, and then we improve the employment as a way to have employment opportunities. Growth in medical tourism, next. Pharmaceutical export growth, then strengthen national health security. So those are what we expect as the Ministry of Health. So Rwanda is strengthening its health system by building a regional platform for health, innovation, service excellence, and investment returns. Next. So, this is a sum of in general, but now where have we come from, where are we, and where are we heading? So Rwanda approach to prevention of and control of communicable diseases. Rwanda's approach, after 1994 genocide, the health system, Rwanda built its, using strong primary care foundation, where we brought up community health and then data-driven governance. Next. So, take an example. We had reduction of under 5 mortality. We had HIV prevalence stabilized at 3%. When we talk about prevalence, you need to think about some factors. Minimize new cases, minimize death. That's when you have increase in prevalence, there are new cases. When you have decrease in prevalence, then maybe people are dying. So because of the HIV program, because of the interventions, at least the prevalence of HIV has been maintained at 3. It's positive. So malaria, maybe you can go to the next. So you have seen we have got life expectancy going up to 69. After genocide, we were around 39, 40 there because of the malaria, HIV, those kind of conflicts that we had in our country. So we were really down, life expectancy was down. So we have managed to reduce under 5 mortality up to more than 80%, around 80%. HIV treatment coverage, around 95%. We have 90 screen diagnosis, 90% on coverage on treatment, then 90% on viral load suppression. So we have at least got to. Before that, next, this is the other one. So malaria, TB and malaria, we have gone down in terms of prevalence. Then immunization coverage is over than 90%. So these are some of the common practice, general practices that are done in terms of infectious diseases. Next, please. Next. Before that, sorry. So now when it comes to non-communicable disease, we are getting a transition from communicable to non-communicable diseases. And you can see that WHO is referring to 50% of death by 2021. And also, Rwanda is also around 50%. We have been having what we have cause of death in the facilities, but also we found that we still have cause of death in the community. And we are doing both. In the facilities, we're using doctors to do the certification of cause of death, but also we have what we call verbal autopsy in the community. So we are doing, under the coordination of the Ministry of Relief for Local Government, we are trying to do also what we call verbal autopsy in the community. So we decreased these kind of infectious diseases. Next. So, and now the issue of non-communicable disease is nothing other than the risk factors. As you know, we have congenital or familial diseases which are more minimal, but also have acquired diseases which are more now rampant. So here the statistics, like you can say on tobacco, we have done a lot. We came from 12 to 7. Drinking, we came from 41 to 48. I'm talking to youth now. Drinking. So, but good thing, the heavy drinking, we are not very bad off. We came from 15, now we are at 3%, so which is positive. And then the fruits and salt, all those things you see, people can use salt, which not necessary sometimes. The physical activity, you can check the obesity here is a problem. Hypertension came from 15 to 16, it has increased. Diabetes has come from 3 to 2. So all these ones are all risk factors that are affecting our people to getting sick. So this is a strong problem, very big problem. Next. So this is showing how now communicable diseases and the non-communicable diseases are trying to cross. We have tried to work on communicable diseases, but now non-communicable diseases are now going up. And the first cause of death in our facilities, you know better than I do, is cardiovascular disease, the diabetes, also cancers. So we need to do much about that. Next. So, our intervention now, because we have seen much on non-communicable diseases, let's talk about intervention on non-communicable disease. We have around 4 strategic objectives. One is on prevention, another one is on health systems, another one on coordination, and then monitoring and evaluation. When I'm talking about coordination of partners, coordination of other sectors in terms of NCD's prevention. So we intend to reduce the premature mortality in one of the indicators of Sustainable Development Goals that we expect in the near future, just 2030. So these ones you are going to read, but these are big lines that we are trying to go. Of course, in prevention, we have awareness, we have policies on tobacco, alcohol, and other risk factors. So health system, that's training of doctors, supply chain, guidelines and the protocols, and so on and so forth. So then strengthening the data systems, research, and so on and so forth. So basically, those are one of the objectives that we are using to control non-communicable diseases in terms of public health aspect, but also in conjunction with the clinical aspect. Next. So we have cancer disease program. So we are talking about the Rwanda's future aspect. So we have cancer disease program that has this other prevention, kind of treatment, other detection, palliative care. We have diagnosis and staging, then monitoring and evaluation. So for the interest of time, I'm just passing through. Next. So we have now, we are trying to manage cancers in Rwanda. I told you, previously we have been transferring patients to India, to Kenya, to Uganda, to wherever, but now we are trying to we want to make a very good cancer center, and I think if you visit there, the doctors will explain to you. Next, please. One of the problems you have now is the kidney diseases, chronic kidney diseases. Whenever we go to do screening of hypertensive patients, diabetes patients, we have so many cases of chronic kidney disease. So it's a problem. We need to treat these people such that we delay the complications. I know we are having kidney transplant in Rwanda at King Faisal Hospital, but still, for example, if you wanted a slot to have somebody operated, the appointment have reached as far as December of this year, late. So we have many patients compared to what is needed. I mean, the resources available, and you remember all those issues of the dialysis, just prolonging the death, I mean life, but this is what is happening. This is for last year, got it from MOH report. So we have also cardiac, so next, this is kidney transplant, next. We have also, on cardiovascular in particular, we have cardiac surgery at King Faisal. All along we have been having the humanitarian support from outside. They come and they operate like around between 20 to 30 patients in a year. This time we are having around between 250 to 300 patients in a year. So it's a very good, interesting change. So besides open heart surgery, we are doing this community awareness. I like the person who's presented about congenital heart disease screening. We are doing it a lot. The way we do it, we have trained nurses and GPs, non-cardiologists. They go and screen. They suspect cases. We take cardiologists to confirm cases. The cardiologists decide who will come for open heart surgery or who will be treated medically. So that's how it is done under the coordination of Rwanda Biomedical Center. So we have a new community checkup. Every Rwandan 35 years and above should go under community checkup for NCDs, and it is paid by community health insurance. So we have the other side, rheumatic heart disease screening, cardiac ultrasound initiative at district hospital, community health worker engagement. Whenever we want to go for screening, we just mention a few of the signs and symptoms. And then the community health workers will go around their villages and do you have, of course they even have them. Sometimes when you tell them, go and look for this kind of patients, they bring them to the facility. We bring the mobile cardiac ultrasound, we screen them, and then we orient them where to go, whether to be treated medically or to be treated surgically. So basically, this is the next. It's okay. Next. For example, this is the slide of a still report from the Ministry of Health 2024-2025. We operated around 195 children on, children, and then 203 adults. You see, we normally have people, many people waiting for surgery. So I think we need to increase, but at least things are being done. So here are some of the challenges, of course, we have. People are not, the three words about knowledge, attitude, and practice. We need people to have knowledge about NCDs, to practice about NCDs prevention, but also such that they should have knowledge, then attitude, how do they do it, and then practice about prevention. So we need to raise awareness. Starting from you guys, the young guys, because we want you to be good doctors, not get sick. The diagnosis with complications, sometimes patients present when they are at late stage. I liked the way of using oximeter. That one could help us to discover patients when they are not in late stages. So this approach, I think I should do. We had a thought at, but we have not made it in a way that is more tangible to start it. So we need to consult you and help us out and think how we can do it. So in efficient supply chain, CVD drugs or NCD drugs, we still have some, but thanks to Ministry of Health and the Rwanda government, most of the drugs now have been, even the open heart surgery, renal transplant, and other medicine are also paid by community health insurance, which is very good for us. So funding for specialized NCD management, still low. Still money is still in infectious disease. Lack of skilled human resource. I know we have HLH. We are trying to increase number of doctors and nurses, but still currently we don't have some in the periphery. They are all located in Kigali, so it's a still. So besides that, we need to think about the solutions, not only the challenges. We have awareness, community health workers, civil society organizations, local leaders, reinforce NCD's community checkup, join access program, improved procurement initiative, increase domestic funding. That's why we are talking about health insurance covering most of these ones. We think about grants and mobilization of funds grants mobilization from partners, in-country fellowship. Like we have cardiology fellowship, we have endocrinology, we have neurosurgery, we have a variety of disciplines that Rwanda has tried to bring it, and I think it is doing well. And then beside that, we need to set up the infrastructure. Without further ado, ladies and gentlemen, I should stop here and say thank you.
Thank you very much, Dr. Everest. But don't go. You can remain on stage as we recognize your impact for developing this healthcare system. So thank you very much with a good presentation on evidence-based statistics, as well as what Rwanda is doing for the improvement of the healthcare system. We have seen that they have also recognized some of the challenges that they are facing and also the solutions to those challenges. And I believe with this information, Rwanda is progressing through the healthcare system. So thank you very much, Dr. Everest. Thank you. Thank you very much again. So we are having our next presenter on stage. We are having a specialist in women's health and cervical cancer. We are having Dr. David on stage presenting about cervical cancer elimination, mostly focusing on it as a pillar of women's health. Welcome, Dr. David, on the stage. So with a round of applause, let's welcome Dr. David. So we are sorry for the presentation for him as he proceeds with the technical team. Let's have our next presenter. We will have Dr. Willie. So we will have Dr. Willie. He's going to be talking about expanding community screening for diabetes and NCDs. So you are welcome, Doctor. So the technical team, please put on the presentation.
Thank you. I am Dr. Willie Mucho. I'm an adult cardiologist, and I'm currently practicing at the University Teaching Hospital of Kigali. This is what I'm going to talk about in the next 10 minutes. I'm going to talk about, next please. I'm going to talk about, next, please. Thanks. So this is the outline. I'll talk about the burden of NCDs, and then I'm going to zoom in on diabetes, hypertension, and peripartum cardiomyopathy. And I'll make a case for screening NCDs among mothers, and I'll finish with actionable points. So we know that we have already shifted to non-communicable diseases. This is the data from the Vital Statistics Report of 2024, which shows that non-communicable diseases account for 47% of death in the hospital, and up to 59% of death in the health facilities. So the transition to NCDs has already happened. We just need to catch up. Now, next please. Yes. This is a scary slide to look at. At the right top corner, you'll see that in 2050, which is not very far from now, by the way, we are going to have about 60 million of people with diabetes. Okay, this is the whole country of South Africa. And with diabetes, of course, I mean, it's an example. It's the whole population of South Africa as it is now. Now, this is the number of people who are going to be having diabetes, and we'll have to deal with that. And diabetes does not come alone. It comes with heart failure. It comes with stroke. It it comes with peripheral vascular disease and all these other complications that we deal with. Next, please. Yes. Now, we know that 85% of Rwandans who are living with diabetes are undiagnosed. And this is about, we need to diagnose them. And all these people who amount to about 130,000, the only way they will be diagnosed is through screening. Because, like my predecessor said, we screen someone who is feeling okay. The patients that we see in the hospitals, they already have symptoms, okay? And that's my job to do, and my colleague there. We deal with people who are already sick, but we need to be more courageous and reach to people where they are and pick up these patients who are asymptomatic but who will definitely develop the disease, okay? And there is a rule that 50% of women with gestational diabetes have a women with gestational diabetes have a 50% risk of developing type 2 diabetes within 5 to 10 years, okay? So you see them, you screen them. Once you see that they have gestational diabetes, you need to follow them up even after they go home, because you know half of them are going to be, they're going to have type 2 diabetes. Next, please. And we should screen them because we know that they will give birth to babies who are going to have the risk of NCDs in the future as well. Now, how about hypertension? The national prevalence, as Dr. Everett said, is 16%. There is a gap of awareness. 50% have never had their blood pressure measured, okay? So you can imagine if 50% of them have never had their blood pressure measured, it means that we have probably double the prevalence of hypertension. So the numbers you have, they're probably low, okay? And we know that patients with, women with chronic hypertension, they have high-risk deliveries. And we also need to monitor patients in the postpartum period between 7 to 10 days, because this is the danger zone where they have major complications. Next. Now, my major topic of interest today is peripartum cardiomyopathy, because I'm a cardiologist. Of course, we want to prevent, but sometimes we see these patients. These are patients I see on a daily basis. These are women who are otherwise healthy, and they come to you with bad heart failure. You look at the heart, it is dilated, and the problem is that most patients with peripartum cardiomyopathy are African or are of African descent, okay? And the mortality in sub-Saharan Africa is about 50%, okay? This is a terrible disease to have, but when you pick it early, you can change the course of the patient, and most of them actually recover. So you may wonder why we don't hear about a lot. Next, please. The reason why we don't hear about it a lot, look at these symptoms of our peripartum cardiomyopathy. So we have ankle swelling, shortness of breath, fatigue, tachycardia. Most pregnant ladies will tell you that they have these symptoms. So they go to the clinic, they tell them that that's normal. And then they come back with very bad heart failure. Next. And then there is, please go back to the previous slide. And the one before that. Yeah, also there is a very big gap in the research. You can see that only about 30 papers have been published in Nigeria, and then these other countries, it's less than 5. So this disease that is happening in Africa, but we are not talking about it, and we are not publishing about it. Next, please. Next. Next. Yes. So how do we diagnose it? You screen for the symptoms. Once the patient has the symptoms, then you have to do either ECG. So you have to do both. You have to do ECG and you have to do echocardiogram. Now, these are not available in the health centers and the communities. Hence, the need for something like the mobile clinic where you can actually do the ECG and do the echocardiogram where the patients are. Next. Now, this is how it looks. That is a normal heart on the left-hand side. On the right-hand side, that is a dilated heart. So when you see it dilated like that, you know they probably have a peripartum cardiomyopathy. You put them on treatment while they're still pregnant, and then after a couple of months, they look, they usually recover, the swelling resolves, and they usually give birth to normal, to healthy babies. And you can follow them up for a couple of years as you're decreasing the treatment. This is the only form of heart failure where we can actually stop the treatment after the patient has recovered. Next. Now, this is something we need to reflect on. So can the new technologies that we're having now help us bridge the gap? Because we know we need to have the skills to do these tests. We need to interpret the ECG. You need to do the echo. Now, this is a paper which was published last year. I actually participated with the recruiting patients when I was still at the Aga Khan Hospital in Nairobi, and we actually proved that with ECG enabled with AI can detect heart failure without the need for echocardiogram. So this is a very good tool. You just apply the ECG leads, and then the AI will tell you this patient probably has heart failure, and then you have to go and screen. Next. And this has been also published late last year in November. This was a big clinical trial which was conducted in Ghana, and they were using a stethoscope. So if you think about it, ultrasound, echocardiogram uses sound, and stethoscope also uses sound. So the only difference is that you don't need to look at the images. So the stethoscope will pick up the sound, and then it will interpret it and tell you if the patient likely has heart failure or not. And it was also shown to have a big sensitivity, high sensitivity. Now, the opportunity in Rwanda is that we already have a strong network of healthcare workers. We have coverage of antenatal care up to 90%. We have, we are going towards universal healthcare coverage, and then we actually have an NCD structure which we can tap in. Next. So what's community-based screening? So this is something which is not done in the referral hospitals. It is done by community healthcare workers. It can be done with mobile clinics. We can integrate our program into the antenatal care, which is already there, and then do the basic tests and at the timing that we've mentioned. Next. So I have 3 take-home messages. The first one is that these simple tests should be done for everyone. Gestational diabetes should not be missed. Hypertension should not be missed. Peripartum cardiomyopathy should not be missed among all these pregnant women. Next. Now, so in order to sustain it, we need to make sure that whatever we do is linked with the existing NCD program and strategy, which is ongoing. And lastly, also encourage us to explore and actually see how we can use the new technologies to leap forward and bridge the gap that is caused by lack of skills. Thank you.
So thank you very much. We are going to recognize your contribution to this event through your presentation. So I would like for the recognition to proceed. And as we hand over his recognition, he mentioned that 85% of people with diabetes mellitus are undiagnosed, and 52% never had BP measurements. So we have to try to deal with this through what we have today from our mobile clinic. I hope it will have a great contribution to the statistics that we have now. So before we proceed with our next presenter, we are also going to recognize our very host of today, the University of Rwanda, and the representative, Chiza, is going to receive the recognition as we thank the University of Rwanda for the collaboration for this event to have went well. So Dr. Kagawa is going to award this recognition, and thank you very much from the University of Rwanda. So let's give them a round of applause. Thank you very much. Last but not the least, we are going to have a presentation from Dr. David Nirushka, and we are going to be hearing from him about the cervical cancer elimination, a pillar of women's health. Let's welcome Dr. David Nirusha on the stage.
Good evening, everyone. Let me start by thanking HDI, University of Rwanda, and the ASTA volunteers for this opportunity and for the invitation. My name is Dr. David Nirushwa. I'm an obstetrician gynecologist with specialty in minimal invasive surgery and global women's health. Next. So the topic for today is going to be about cervical cancer. It's a little bit different from other topics we've had. This is really a dear topic which affects mothers and women. And to start it, I know that I shouldn't be the one talking about it, but it's still the women themselves, those who suffer the most. And as you can see there, I want to start by a woman who have accepted to really provide us her words, who had cervical cancer. So the woman has presented by saying that my daughter is young, she's a teenager, and yet she had to look after me, dressing my wounds, which had broken through my skin for a long time. I had to put up with pain which went through my whole body, especially in my back and my lower body areas. We had no morphine at home, and so I was in a terrible state. I grew up in a poor family, and we didn't have information about HIV and cancer. Often it is too late when people go to the doctor, and most people don't even know the signs. If I had the chance, I would love to be part of a campaign to tell people about it. The clinic need to help us more. Be aware of this, especially about cervical cancer. We need more testing. This is a word from a woman who had cervical cancer. And as you can hear from her, there are a lot of things that we can learn. We understand the severity of the disease. So meaning when she had it, she couldn't move. Her daughter, who was supposed to be in school, had to take care of her. She had pain, but she couldn't get even medication. It shows systemic failure because this woman never knew about any sign of cervical cancer or whether she could even have preventive services. We know about the social determinant. I know some of you might be, some are medical students, some others are clinicians, policymakers, and so. Whatever we can do, the determinant of health are very key. When someone is poor, cannot afford to come to the hospital, even when we have everything. We see integration impact, the lack of, probably this woman has given birth, we are sure, because she had a daughter, but no one told her about cervical cancer screening and elimination, which could have been an opportunity. Economic implication, this woman couldn't work. She was at home with her daughter. You can imagine how much they were suffering. So we can even see intergenerational impact. It's the woman, but we can see what is happening to her daughter. Probably this daughter is also going to be suffering. So it's really more than a disease. That is what I love from this initial presentation. And this is what women tell us who are suffering from the condition. Next slide. So if you look at this map, it's really terrible because to show that cervical cancer is still very prevalent, and especially in more low and middle income countries. If you look in red, most of African countries have a prevalence or an incidence of cervical cancer which is still above 260, and this is really too much. And when you look at the number of new cases in 2018, when we have the data, we had around 570 new cases which has occurred, and we had around 310 mortality due to cervical cancer. 90% of death or new case of death were from low and middle income countries. Again, it shows inequality. All of us who are seated here would wonder, why do women living in our countries, low and middle, low resource settings, do have to die of a condition which can be preventable? Next. So this is a natural history of cervical cancer. I think this is a condition that we all need to know. When I look at it, I see opportunity, because when you consider other cancers, sometimes we don't know what is the cause. But for cervical cancer, we know that there is a virus, which is HPV. We know that this virus is very common, the most prevalent sexually transmitted infection. And when we look at women's life course, at least 3 in 4 women have contacted HPV. Fortunately, we have the immunity, which allows us to allow most of the women who get the disease not to suffer from the cancer. But when you look at it, it takes years to become cancer, and the opportunity of having screening and so before the disease is out there. So why do women keep having a condition which we can prevent maybe over a period of 10 years before it becomes a condition? Again, this is something that I consider as a tragedy, but we have opportunity. This is the cervix. I know this image might not be very interesting, but the first image here shows a normal cervix of a woman. The second image shows a cervix which has started having some transformation. It doesn't have cancer. And this second image, a woman can be having it for 10, 15 years without any sign, without any complaint. If the woman comes during that in between and we identify that there is a precancer lesion, we can treat her. We can even tell her you don't have any risk of having cervical cancer because we are able to treat. However, if nothing is done, the cervix ends up by becoming that way. I tried to look the less threatening image because other image of cervical cancer would probably result into emotion into this room. So we need really to understand how this is a huge problem. Next slide. So fortunately, in 2020, this was during the COVID. I think the group effort did something huge because they started the campaign for the elimination of cervical cancer. Elimination-wise, because this is a condition which can be prevented. Because looking at the natural history, we know what causes it. We know that this precancer region can be there for many years before they become cancer. So they put on a strategy to eliminate it with possibility of eradication. Next slide. Let me focus on these numbers. These are numbers by WHO elimination strategy for cervical cancer. They are very ambitious. The plan is that all girls can have HPV vaccination, at least 90% of them, if they are aged between, by the age of 15. And this is something which can be done, and some of you might know that in Rwanda we have been vaccinating young girls. Then the second target is to screen all women by the age of 35 years, then by the age of 45 years. Screen mean what? To test whether there is HPV infection, and as I said, HPV is the most prevalent infection. Then 90% is to be able, whenever we find any precancer lesion, to be able to treat it. Or when someone is diagnosed with early cancer, to be treated as seen on the above cervix. So this is ambition, but this is possible. So why do we think cervical cancer elimination is key? And when we talk, or we come to motherhood, one of the reasons is because it's a very preventable condition. No woman should have it. And we know that it affects mainly African women, including Rwandan women, still have it. And then this is a disease which comes earlier in age. So we see women who are aged 30 years, 40 years, 45, before 50 years, having cervical cancer and dying of this condition. So we can definitely be able to treat it. Next. We have opportunity, and I think the main message that we can take, because the HPV usually start at around, people get exposed to it at around 15 years when they start becoming sexually active. There is a time which is given to have precancer region, and as you can see, up to the age of 30, we usually don't see cervical cancer, but after the age of 30, this is the time when the disease starts being seen. So we have the opportunity that from the age, before the age of 15, before the young girl gets contacted with HPV, we can do prevention. And then after 15 years, we can do screening. Usually, you will see that different countries have different screening program, some at 21 years, others at 30 years. Next. Next slide. So this slide shows that we can stop cancer before it occurs. And as you can see, when this is a study which was done comparing women who have been vaccinated to those who did not. And as you can see there, the incidence was very low for women, young girls who were vaccinated when they were in the older age. So again, it pushes the importance of vaccination. Of course, screening also have a huge impact. Next. What about safe motherhood? So safe motherhood means that we need to have mothers pregnant in the reproductive age who can just give birth when they are healthy. And safe motherhood means that we have to intervene before pregnancy, during pregnancy, and after pregnancy. Then cervical cancer, as we've seen, can affect women reproductive age. That's why we don't have to wait to come for screening. So if a woman has cervical cancer, there is high risk that when she's pregnant, she can be affected. The morbidity and mortality is higher. Then again, we've seen that when a woman dies in early stage, like the woman who had already cervical cancer whom we started with, the babies, the children are going to suffer. This is really very key for us to understand that cervical cancer is somehow related to motherhood. Next. What about Rwanda? You might be wondering like what Rwanda has done. We know that the health system of Rwanda gives an opportunity to prevent and to reduce cervical cancer. One is that we have started vaccination for cervical cancer. We have community health workers whom we can use to educate. Then there is digital health, which is growing, decentralization, then all of this making opportunity for elimination of cervical cancer. What are we doing and what do we have? On next slide, you can see that here we have acceleration plan for elimination of cervical cancer between 2024 and 2027. This is a huge opportunity. But you can see also some other image showing that we still have a lot of women who come with advanced stage of cervical cancer. And this again is a tragedy because no one should have it, or they should be treated when at least they still have early disease. That next picture shows us vaccination status, and as you can see, we are having vaccination of young girls below 15 years above 90% consistently. And then the screening has also been growing. Next slide. This is a map of Rwanda showing the program in Rwanda. And really over the recent years, we have been seeing effort to increase the screening of everyone who meets the criteria. And what do? All women above the age of 30 years are screened using HPV test to see whether there is HPV virus. Then they have what we call VIA. But for women who are HIV positive, we start screening at the age of 35 years. And as you can see, Rwanda, we are starting to have many districts which are in the green, meaning that they have achieved the strategy, the screening strategy. But we still have some districts which are still, which do not have even screening methods. So the fight is still at the start. Next. There are some barriers for cervical cancer screening. And as you can see, there is awareness issues. There is financial constraint where women cannot come to the hospital. There are distance to health facilities, lack of community empowerment. All of this leads to really are just barriers which affect the elimination strategy, which include HPV testing, HPV vaccination, screening, and then early treatment. Next slide. What do we need to do in the community? Because we see that community awareness is a big issue, and today's presentation is focusing on that, we need to use community hall focus. We need to engage the community. Then we also need to make sure that the community is taking initiative, which is driven by themselves. Next slide. This is an image from this today. When I was looking at this mobile clinic, I was thinking about the innovations and the opportunity which are within there. Because we have women who cannot, we have poor women who cannot reach the health facilities. These women can be leashed, and all of these factors which prevent women from having access to screening methods can that definitely benefit them. So this is really kind of equity to a number of women whom are having some health determinant affecting them. Next slide. Universities have also responsibility, of course, and this is clear. There is training, there is implementation research, we need to have innovation in screening and so, and this is a huge responsibility. Probably do not have enough time to focus on this more. Next. So today I was in a clinic. I had a woman who is educated, university level, who have children, who is an educator. She came aged 38 years. She has been consulting all the health facilities from the last 20 years. She had 4 children. And she has had 2 emergent laparotomy. One was when she had a twisted ovarian cyst on her second pregnancy. The last one was last year, just in July, when she had the ruptured ectopic pregnancy. This woman, when I talked to her about cervical cancer screening, she screamed and she said, "I don't want to be associated with that." And this is someone who is educated. Then I asked her, "Do you have information about screening?" She said, "Yes, but I don't have to be part of it." Meaning that we still have a long way to go. It's not only sensitization. It's not only making sure that we have communicated, but we need to do more. But I asked her a question, if you get cervical cancer, what do you think of your children, the 4 children? She didn't respond, but when she was on bed, when we were doing ultrasound, she said, "Doctor, can you also please screen me? Because I love my kids." So we need to do more. So meaning that the lesson I learned from there, education does not guarantee preventive action. We might see doctors, people educated, not being screened because they feel like cervical cancer is not part of what they can have. Again, availability of resources does not equal utilization. Again, this is an example we've seen. Stigma is key, and we need to make sure that we're educating. Then demand is behavior, not information. We all know that drinking, exercising, doing everything we know this will help, which promote health, can help us to live longer. But sometimes we don't care. We don't care about physical exercise and so. So it means that probably we need to do more to make sure that one is seeing something as a demand and something important. So in conclusion, cervical cancer can be eliminated if we work together. We trust that as the audience here, you can contribute. Thank you so much.
Thank you very much, Doctor. I won't go beyond what you said. Cervical cancer can be eliminated, and we need our contribution. Please, women, go for screening as early as possible so that we achieve this milestone. Thank you very much, Doctor. A round of applause as we recognize him. So are we still together? If you hear me, you do 1 clap, and then we go for 2 claps to 5 claps. So if you hear me, 1 clap. If you hear me, 2 claps, 3 claps. If you hear me, 4 claps. Then 1 clap, 3 clap, 2, 1 clap. So thank you very much. So we are having our last speaker, Dr. Afak Parvez. He's a specialist pediatric cardiology at Astor Hospital. He's going to talk about the diagnosis and treatment of common congenital heart diseases in children. You're welcome, Doctor.
Thank you very much, the sponsor, the organizers, Astor volunteers, and my dear colleagues. Actually, it is a late presentation, and it may be not very interesting, and already Dr. Edwin has presented the very important part of the topic, so I will be very brief. Next, please. So I will be just talking the theoretical part of the congenital heart disease. That is, in children, we can have either congenital heart disease or acquired heart disease. So as all of you know that congenital heart disease is something which is present from birth. I mean, it develops during the fetal life. And acquired heart disease is something which develops during the lifetime, either due to some infection or autoimmune phenomenon or other processes. Next, please. So this is broad classification of the congenital heart disease. It can be either acyanotic or it can be cyanotic. Acyanotic means anything which don't cause desaturation of the, it don't show up as blue color skin or mucosa in the children. And the cyanotic is the opposite. So we are more concerned about the cyanotic heart disease because it is more scary and more critical most of the time. And even we have further subclassification like acyanotic or the shunt lesions as we commonly know them can be subdivided into something which increase the pulmonary congestion. It causes more pulmonary edema, and it can be, on the other hand, it can be obstructive also. The cyanotic heart disease is usually due to decreased pulmonary blood flow, either due to obstruction to the pulmonary artery or other levels. And it can be, also it can be due to complete mixing inside the heart from the left and the right side of the heart. Next, please. So this is just quick examples of some of the common acyanotic congenital heart disease. Maybe you have heard many of the names like atrial septal defect, ventricular septal defect, patent ductal arteriosus, common AV canal defects, and like others. Others are more rare examples. Next. So this is the other arm of the acyanotic congenital heart disease, which is caused by obstruction at some level inside the heart. It can be like valvular obstruction, like pulmonary valve. It can be having obstruction at various levels, below the valve, at the valve level, or above the valve, which is called supravalvular, subvalvular, or valvular. Similarly, the aortic valve can have obstructions. Then there is coarctation of aorta, which is very important disease because usually it is like a critical heart disease coming in the infancy or newborns. We have other more rare disease And there is regurgitant heart disease also, that also falls in the acyanotic heart disease. Next, please. Now, the cyanotic heart disease, which is causing arterial desaturation, it have like very complex and scary diseases, the most common of which are like tetralogy of Fallot, complete transposition of great arteries, then total anomalous pulmonary venous drainage, and some of the rare one like single ventricular physiology or hypoplastic left heart syndrome. Next. These are some miscellaneous congenital heart disease. It is very rare and maybe not relevant to you, so next please. And not to forget the acquired heart disease, because these are also very common, and maybe as a community we face these problems more often than the congenital one. Like rheumatic heart disease, which is like inflammation of the valve or the various other heart structures due to the streptococcal infections, and it is an autoimmune phenomenon actually. Then Kawasaki disease, which is the dilatation of the coronary arteries due to preceding infections, and it can cause to severe heart failure later on if it's not recognized. Then infective endocarditis, which is also very common in prolonged hospital stay due to any other focus of infection. It can affect the heart. Then various cardiomyopathies, which can be genetic, but as well as it can be acquired, like maybe you have heard the name dilated cardiomyopathy, hypertrophic cardiomyopathy, like it is very common in common phenomenon in athletes. If we don't screen for that, it can cause sudden cardiac death. Then there can be restrictive cardiac disease. I think it is common in this continent also. It can be due to the thickening of the pericardium or other issues. Then there is arrhythmogenic cardiomyopathies due to prolonged tachycardia or other fast heart rate phenomena. It can cause chronic heart failure. Next, please. So these are the various diagnostic modalities. Some are very common, which we see everywhere and we do every day. Even in the mobile clinic, we can find these like ECG, chest X-ray we usually have in hospital, but it is very important to diagnose or at least suspect any congenital heart disease. We have then echo, which nowadays with technology, it is coming more portable and we can take it anywhere, even in the mobile clinic or in the peripheral regions. And that is the first like gold standard for diagnosing any congenital heart disease. We have other tests also which are more complex. Usually we have in tertiary care hospitals like Holter and exercise test and CT, MRI. Those are all like for the final confirmation and management planning. Next. I will just touch upon some very common heart disease and how we approach them and how we manage them. Like atrial septal defect, which is a defect between the upper two chambers of the heart, and it is very common to have, and usually they present very late. So if some old children or adult are coming with suspicion of congenital heart disease, most likely it will be ASD. And if the shunt, it causes the shunt from the left side of the heart to the right, and if it is large, they can present with symptom even in childhood. But usually the symptom develops later on when the heart dilates. It causes arrhythmia or it causes pulmonary hypertension in the 30s or 40s years of life. So this is very like if you put a stethoscope on patient and you are suspecting ASD, you will feel like the second heart sound is very wide and fixed split. So very unique sound. I mean, you should try to listen to the YouTube or something. Then we see ECG and X-ray features which showed the dilatation of the right side of the heart. If you see in the X-ray like the RA is dilated, that means the right border. So you should suspect ASD or other similar conditions. Next. So you can see the X-ray here. Here the right border of the heart is looking like bulged. So it is dilated right atrium. Then in the lateral view, you can see the heart is almost touching the rib case. So it is the dilated right ventricle. So these are like simple ways to detect or predict these diseases. And in the upper cartoon, you can see the various types of ASDs. So as a management, usually the surgery and or the catheter, I mean the device closure is the way. But nowadays, we are more focusing on the device closure because it is non-invasive, and if the case is suitable, we do it in a cath lab with a pediatric cardiologist. Otherwise, we do open heart surgery, and usually surgery is done after 4 years of age. Next. So second is the most common congenital heart disease, which is VSD. And it is like among all the congenital heart disease, it is almost 20 to 30% of the patients have this defect. It can be either standalone or as combination of other defects. A small VSD patient is not affected. I mean, usually asymptomatic, just we hear a loud murmur. So we put to state, we find the murmur, and we can suspect either there is something very pressing reason to do echo if we found this murmur. But if it is a moderate to large VSD, even in infancy, the baby can present with failure symptoms like fast respiration and failure to thrive and difficulty in feeding. So in that case, we have to plan surgery very early, like even before 6 months of life. And we should start medical management with the diuretics, Lasix, and other things. There are other ways to find by auscultation. The same way we can do predict the VSD like lesion by X-ray if there is cardiomegaly and there is pulmonary congestion. Next. So this is like a X-ray showing VSD. You can see the left ventricle is dilated here, so it is the apex is more enlarged. And the next cartoon shows various types of, even the VSD, we have various subclassifications. Next. So in VSD and other similar lesions, the most important thing is not to delay the surgery, because if we delay, it can cause a permanent increase in the pulmonary blood pressure, that is pulmonary hypertension, or it's also called pulmonary vascular obstructive disease. And it depends on the genetic and other factors and the type of lesions. It can develop as early as 1 year of age. So, and if you know that the final problem which happens is Eisenmenger syndrome, that is permanent increase in the pulmonary pressure. So the usual surgery for the VSD is open heart surgery, but if in selected cases like muscular VSD and others, we can do device closure, which is minimally invasive treatment. Next, please. Then the third lesion is coarctation of aorta, which is also very important in neonatal life, and it can be up to 10% of all congenital heart disease. It is obstructed kind of lesion in which there is narrowing in the preductal or postductal region of the aorta. It is sometimes associated with Turner syndrome, and the baby present with like a shock-like state, poor perfusion, and severe acidemia. The usual way we say that even we can screen, anybody can screen for this if they suspect by doing the 4 limbs blood pressure. Like you have to measure the blood pressure in all 4 the left and right arm and the 2 legs. And if there is discrepancy between the upper and lower limb blood pressure, it points to this diagnosis, coarctation of aorta. So very important, this one. And X-ray showed cardiomegaly or pulmonary edema. So to confirm diagnosis, usually we have to do sometimes CT scan apart from the echo. Next. So this is some cartoon showing the coarctation. You can see the area of narrowing. And if the child is grown up after coarctation, he developed collaterals like circulation from the upper part of body, arteries coming from the upper branches of the aorta to supply the lower part of the aorta and arteries. It is called collaterals, and in the X-ray you can see this as evidenced by rib notching, because the intercostal arteries have increased flow and they cause loss of the part of the rib. Next. So management of coarctation of aorta is usually surgery, especially in the sick infant. But sometimes we can do balloon dilatation of the aorta. This is again a cath lab procedure. But if there is recurrent coarctation, that means we have done initially treatment for coarctation of aorta. And again, there is recurrence of the narrowing of the aorta. We do balloon dilatation only, which is a non-invasive way. And older children and adults, we usually do stenting of the coarctation, which is like very effective in that population. Next, please. In the cyanotic part, I have one like complete transposition of great arteries, which is not very common, but usually it is very critical disease, and the child is cynosed since birth, like very poor saturation, sometimes below 50%, because the pulmonary and the systemic circulation are completely separated. The aorta is coming from the RV instead of the left ventricle, and the pulmonary artery is the opposite, like instead of usual right ventricle, it is coming from the left ventricle. So the two circulations are like parallel, and there is just two small connections like PDA, which is patent ductus arteriosus, or ASD or PFO, which is connecting the two parts. So there is no mixing, and there is no oxygenation going to the whole body. So we have to intervene very early in this case. Usually first step is to do septostomy, that is to make the ASD or the PFO to enlarge that defect, that there can be more mixing. And the final, next please. So you can see in this diagram that the normal heart, the pulmonary artery is coming from the right ventricle, but in the transposition of great artery, it is coming from the left ventricle. And the two circulations are parallel, that there is no connection between. So all the oxygenated blood is going back to the LV and again pumping in the same circulation, not mixing with the aorta. X-ray shows like heart failure. Next. So the treatment is, of course, surgery, which is called arterial stitch operation, which is very complicated surgery and done in only tertiary centers with very experienced surgeons. But we can manage initially the patient, such patients we should manage in the NICU itself by giving prostaglandins to open the PDA and to give inotropic support to prevent the cardiac failure. Next. Last, this TOF, tetralogy of Fallot, already covered by previous speakers, so I will not go with that. Okay, next please. Next. Next. And the last, which is very scary, maybe you have heard the name, it is called hypoplastic left heart syndrome, in which there is the left side of the heart, like left ventricle or the aorta and the aortic valve, they are very small or stenosed or not well formed. So this is very rare, like occurs in 1 out of 5,000 live births, but if it happens, it is like lifelong disease, and usually there is very high mortality during the first year of life itself. Usual treatment is cardiac transplant. That is the most effective way, but unfortunately not available everywhere. So the best way for such cases, such complex cases, is to do the fetal screening itself, like fetal ultrasound and then fetal echo. And if we can diagnose these diseases before the 3 or 4 months of gestation, we can go for medical termination of pregnancy. Next. So this is the diagram showing this defect. You can see the left ventricle is so small, and the whole left circulation, like aorta, aortic valve, and the arch, aortic arch, all are smaller. And if the baby is like diagnosed with this very late, and we cannot do termination, we have to deliver the baby. So either we give the parents the option either for the compassionate care, or we go ahead for this complex surgery, which is multi-stage. And I will not give the details, but it is very complex surgery and have very poor outcome. Next. Next. So the take-home message are that congenital heart disease are widely classified based on the anatomy and physiology of the lesion. There are many tools available for diagnosis. Sick newborns are first present to the peripheral healthcare giver and should be managed medically first. And then the specialist come to diagnose and give the further plan. So in many cases, it can be handled or completely treated by cath lab procedure, that is non-invasive procedures. But the final destination is to do open heart surgery, which is complex. But if once it is treated, it is give lifelong resolution of the problem. Okay, thank you. That's all for the.
Another round of applause as we thank Dr. Afak Parvez, and as they give him a recognition for his contribution to this symposium. So we would like to call upon the HDI team lead by Dr. Kagawa. And Mr. Richard, you are invited. And the HDI team, so that we reward this recognition to Dr. Parvez. Thank you very much. So we are also recognizing HDI for its great partnership. So we would like also to give the award to HDI team that is led by Dr. Kagawa Aflodis. Thank you very much for your contribution. A round of applause, please. So thank you very much. This marks the end of our symposium, and it was under the theme of empowering communities, protecting mothers, and saving lives. And I'm not the one going to give the closing remarks, but I would like to remind everyone that we were reminded that healthcare transformation doesn't happen in isolation, but it needs partnership to achieve the commitments we have in accelerating the healthcare system. So thank you very much for having me. You were with MC Dr. Agnes Irachiza. I'm currently working at the hospital at Masaka. It's in the district area. And thank you for having me today, and I hope to meet you in other different events. So allow me to welcome Mr. Richard Kabera, the ASTA volunteer representative Rwanda, to give us a closing remark. Thank you very much.
Good evening, everyone. I want to start by giving a heartfelt thank to the moderator. She did an amazing and awesome job. So, Dr. Agnes, thank you very much. I want to add something on what she says. So where she works is actually the medical center, where Rwanda is currently doing the medical center. So I also invite you to visit that place. So as we conclude this medical symposium, I want to extend my heartfelt thanks to every single person who contributed in terms of time, energy, and putting all this together. So thank you very much. Special thanks goes to the ASTA team from GCC and India. Welcome to Kigali again, and we look forward to doing more good things. Special thanks to the HDI team, the Ministry of Health, but more importantly, the University of Rwanda, the student, the staff. Thank you very much. Hoping for us to do something bigger and better next time. You're welcome.
They brought me back on stage. They wanted me to announce that there are snacks outside. We can go for the snacks and networking. Thank you.
Inclusion is critical to the CMU Africa mission. It's critical to the success of the next generation of African students, entrepreneurs, and business people.
Entrepreneurship is a choice. It's tough, it's really hard. So it comes back to individuals being able to be resourceful, being able to tap into a network of opportunities, but most importantly, the broader investment community and government partners that are able to nurture small ideas and help them to succeed.
Ensure that you have that best, that technical skill. What's your technical area of work that no one can take away from you? And you combine that with soft skills. Are you able to identify a problem, articulate it properly, and think of the possible options?
It is important as an entrepreneur to really immerse yourself in understanding that which you are trying